It is my distinct pleasure to welcome you all here today for Department of Medicine Grand Rounds. We are honored to have with us Dr. Amit Kumar Pahwa, an esteemed physician, educator, and also a close friend, and a leader in the field of hospital medicine and medical education. Dr. Pahwa is an associate professor in both Division of Hospital Medicine in Department of Medicine and in Division of Pediatric Hospital Medicine in Department of Pediatrics at Johns Hopkins University School of Medicine. He has dedicated his career to advancing high-value care, improving medical education, and shaping the future of healthcare delivery. I recall when Amit was joining us at Hopkins from Indiana University, completing his residency program. So I tried to sort of pull him towards doing some clinical research, but he really wanted to delve more into education part and work more closely with Lenny than me. But I think that was great because that's where his passion was, and we can see how he has progressed in his career through his dedication, through his hard work, and he quickly distinguished himself as a leading voice in high-value care across the United States, not just at Johns Hopkins. His commitment to this mission has not only shaped institutional policies at Hopkins, but also influenced national discourse on cost consciousness and high-quality patient care. As the founder and executive director of the High Value Practice Academic Alliance, Dr. Pahwa has been instrumental in promoting cost-conscious, evidence-based medical practices across the nation. His work as the physician lead for the Johns Hopkins Health System High Value Care Committee has contributed significantly to enhancing efficiency and patient-centered care within one of the world's most renowned medical institutions. Beyond his leadership in high-value care, Dr. Pahwa has made substantial contribution to medical education. He serves as director of the Pediatric Hospital Medicine Fellowship Program at Johns Hopkins Children's Center and has played a pivotal role in developing innovative curricula at Johns Hopkins. His scholarship includes numerous publications focused on healthcare value, patient safety, and medical education reform. Dr. Pahwa was planning to join us, as we were discussing earlier, in person, but due to weather, he couldn't come here physically. He's joining us virtually. Today, he will be sharing his experience on high-value care in hospital medicine, an area where his insights and experience are extremely valuable. Please join me in welcoming Dr. Amit Kumar Pahwa.
Thank you, Dr. Kayam, for that wonderful introduction. For all of you sitting in the audience, I met Dr. Kayam many years ago when he was a hospitalist here doing great work and inspired many of us to pursue the mission of research at Hopkins, whether it be in clinical research or education. So when he asked me to do this, I resoundingly said yes. And again, I'm sorry I couldn't be there in person. I wish I could see you all right now, but I hope to come one day when the weather's a little bit better. I do apologize for doing this virtually. I wanted to spend today talking about, as Dr. Kayam said, something that's very dear to my heart, which is high-value care, where I started kind of my educational and QI work here at Hopkins, and try to have spread that nationally. To help better serve our patients and give them the best care possible at the lowest cost, if possible, too. So I will start talking. And I have some points in here to break so that I do realize as an educator, an hour lecture is not the most efficient way of passing knowledge. So we will try to break a little bit here so that you guys are participating and part of this lecture or session as well. I am going to kind of minimize things. So if anyone has anything to say, please just yell out or say something if I don't see you. All right, so make sure this goes. All right, just say I have no disclosures related to the presentation financially, except to say that as any physician in this world, I sometimes do practice low value care. So realizing that, we're all not perfect in this situation, but we try to get as good as we can. As with any CMA talk, there are objectives. So by the end of this talk, you'll be able to explain how hospitalists have a role in value-based care, describe some methods for implementing value-based care, and give examples of value-based initiatives utilizing specifically elimination of internal variation, which I'll talk about. Another disclaimer is all the work that I'm presenting was done at the Johns Hopkins Health System, and this is by no means to say that we are the leaders or we're the only ones doing this work or we're doing the best work. It's just that what I've been most familiar with and what I've been able to work on, and that there is a lot of work in this area occurring nationally. And as Dr. Kaya mentioned, we do lead this organization called the High Value Practice Alliance, which many people are doing great work in there, and hope to share some of that work with you at the end really quickly. Before I ever talk about high value care, I feel like when I first started in the field, there were so many definitions, and I think there were people's own internal definitions of this. I tend to like the one that goes from the Institute of Medicine that says, the best care for the patient with the optimal reserve for the circumstances, delivered at the right price. And as a hospitalist, I like to also add here, at the right time. Because as a hospitalist, sometimes a test or diagnostic imaging is best sometimes done as an outpatient. Sometimes it's best done as an inpatient, and we have to realize when that should be and when that should not be. We'll take a few minutes to talk about, well, why does it matter in hospital medicine? And apologies to those who are not in hospital medicine, but again, as a hospitalist, this is where I practice most of my time. There's a lot of data out there. And then, what's interesting is when I started talking about this in 2010, 2014, there wasn't. But now, increasingly more and more stuff out there to kind of talk about why this is important. So as you can see here in a JAMA IM article back in 2017, this author did a study looking at physician spending and looked at Medicare data, so specifically patients who were covered by Medicare, and looked at physician spending based on Part B rates, and then looked at outcomes including 30-day mortality and 30-day readmission rate, which is something that we use as a quality metric in hospital medicine. And as you can see here, all the crazy little dots everywhere, physician spending was all over the place. And really, if you kind of draw this line, there is no line that shows any correlation between physician spending and 30-day mortality rate or 30-day readmission rate. Physicians that were spending very little had just as much mortality and readmissions as those who were spending a lot. And they try to do a really good job in this article, if you ever go and read it, of controlling for confounders and making sure that they controlled all the variables possible. I thought they did a really good job of this because, as you can see, someone could say that, well, I see a lot of sick patients and therefore I'm going to spend a lot more money. But they did a lot of good jobs with controlling some of this. SHM, our organization, Society of Hospital Medicine, was one of the first organizations to partner with Choosing Wisely and come up with those lists. And so we had one that, this first one that had 5 on it. Interestingly enough, Choosing Wisely has somewhat disbanded a little bit and now relying on the organization. So you can't actually find this list anymore unless you dig deep into this article that was written a few years ago by some people you might recognize on here. So I want you to take a minute, I told you I'd pause, and think about how many low value practices have you noticed in your clinical work over the last month. And for those of you on Zoom, you can type it in the chat. Some of you can shout it out over the microphone, however you like. I'll just give you guys a minute or two to think about that. I'll be amazed if anyone says 0. I guess either I can't hear or there's been no low value care in the last month. I don't know which one, but I don't want to take up too much time. You guys can obviously chat or type in later. But what I was trying to lead into with this was they actually asked residents at UPenn. I think this was back in 2014 and published in 2016. Specifically IM residents and general surgery residents, when they saw unnecessary ordering. And so you can see here, it's a lot. So if you were saying that you did see some, you're in the same company as many other people. And they saw it, and 50% saw it almost every day. And some of the reasons that they said were some of the things I think many of us saw when we were residents, or you probably still see today, that they're kind of trained to order repeating labs. You know, although there's been a little bit more cost transparency, the data on that's kind of murky about whether that helps or not. A lot of people are worried as a student or a resident, like, is my attending going to ask for that and I won't have it the next day? And then lack of role modeling of cost-conscious care. A lot of times in the academic setting, we're often praising people for finding odd things or weird things, and we never really take a minute to say, like, it's a good thing you didn't order that test because it wasn't really necessary. So how does this, affect our physicians overall? So in this other JAMA article, this really talked about imprinting. So many of you, although you don't realize it, that are at least post-residency or in residency right now, a lot of your training imprints upon you, and a lot of that goes on once you leave residency. And so what they looked at here was PCP's expenditures by training region, and then their eventual practicing region. So for many of you who are not familiar, the Dartmouth Atlas split the United States into these like hospital referral regions. And this was kind of the article work done by, like I said, the Dartmouth people, and highlighted by Atul Gawande when he talked about 2 Texas towns that spent way different money and had no difference in mortality rates. But in this one, they looked at kind of the Medicare expenditures of comparing when the physicians were in training and when they left training. And what you can see here is overall, we spend a lot of money, whether you're in low or in high region on our Medicare patients. This is kind of the, always talked about the, 7,000, although it's a little bit more now in today's data, but to $7,000 to $10,000 for a Medicare beneficiary. It's up to probably about 13, 14 now. But what I like to show in this slide is if you are eventually going to go to a high practicing region. So whether you practice in a low average did residency in a low average or high training region, you're still spending much more than your counterparts were when they were in the low spending region. But if you were in if you trained in a high spending region and stayed in a high spending region, you spent significantly more than those who were in a low spending region in training and then went to a high spending region after their training. So this shows that imprinting a little bit works, right? So those who were imprinted with that the low spending kind of mentality kind of stayed a little bit low spending, but those who were imprinted with a high continue to be very high when they left. And as hospitalists, I talked about lack of role modeling. Well, eventually, if there is any role modeling, who is it that's kind of talking about this? And so this was actually pediatricians looking at rounds, because during rounds at many pediatric centers, it's called family center rounds, and they do the whole thing in front of the patient. And they were able to observe rounds and see, who were the people initiating the HVC topics? And as you can see here, most of the time, it was the attending, or as you know now, there's a PHM fellowship. And, this is not surprising, right, that it's probably the attending or the fellow doing this, because they're kind of doing the big picture thing, whereas the medical student or the resident may be doing a lot of the clinical work that they may not have the time to dedicate to it, and also the training. So for those of you as attendings, we're the ones that probably should be bringing this up, and that's why I put this slide up here, is that we should be the one initiating the conversation, especially if it's not been initiated by the medical student or the resident during the time. I put this up because sometimes we forget about our patients. We're doing all this stuff and we don't really get a lot of knowing what's going on with our patient, both financially in the hospital and post-hospitalization. And I found this article very interesting. And it talked a lot about how a hospital visit can hit your paycheck. And as you can see here, with the average person making about $45,000, that period of hospitalization really hits them pretty hard, and they're not making as much money anymore. And a lot of this has to do with the fact that they're probably spending money on medicines, doctor's visits, all sorts of things, and may not be able to return to their work as much as they would like. And as you can see down here too, in the bottom right-hand corner, out-of-pocket spending goes up significantly after hospitalization. And this may be some of the medicines that we start, maybe referrals. So just understanding that our patients walk out sometimes with more expenses than just the hospitalization itself. And then the top right one was just to show you, a lot of people think, oh, well, maybe it's the Medicaid population or Medicare population or even uninsured, but honestly, it's even those with employer coverage. So many of you sitting in the room right now who have employer coverage could be hit by this as well. So understanding that a hospitalization, while expensive in itself, also can lead to post-hospitalization further expenses down the road as well. And then another aspect to think about too, whether you're thinking about inpatient versus outpatient, is kind of downstream. So a lot of this, post-hospitalization / post-healthcare visit can be from downstream testing, and realizing that every test is not just one test. And so Dr. Ganguly did a lot of good work around these downstream cascades that occur after certain tests. I thought, if you have a chance, you should look at her work. It's really interesting. The one that she found a positive cascade, meaning there was less testing, was troponins, and specifically high sensitivity troponins. So people get less testing after getting high sensitivity troponins. But much of her work shows that really, honestly, a lot of our testing leads to cascading of low value tests. So this one, she was specifically looking at low back pain, which is something that is measured by HEDIS. So some of you are outpatient doctors know about this kind of set of quality markers. And they found higher out-of-pocket spending specifically for our high deductible, high plan members. So as you guys may know, high deductible health plans are a huge part of and becoming bigger in society because a lot of people can't afford their premiums without having a high deductible. And they found that people who got an X-ray for low back pain that was probably not needed, you could see that they end up spending about $50 to $100. And if they end up getting an MRI, they end up spending anywhere from $200 to $500 out of pocket. And a lot of this has to do with kind of the downstream effects that occur after this, where they may need more imaging, or they end up going to a surgeon for evaluation, or they end up getting surgery. So realizing that some low back pain does not need imaging, and that those who do get imaging are more likely to may get downstream testing that may not be necessary for them and may cost them a lot of money outside of their own fixed expenses. All right, now that I told you a little bit about kind of why we have to think about value in medicine, I'm going to talk about some methods, specifically ones that we're using here at Hopkins, and should be kind of the framework for what we're using across the United States. So three big ones that if you talk to anyone are using pricing, standardization, and utilization management. I'm not going to talk much about pricing because as hospitalists, a lot of that has to do with the C-suite and other organizations. So we don't really do a lot of that, although if you're a hospitalist that sits in those areas, you may be able to improve some of the costs that are to the healthcare system from negotiation and internal sourcing. I will talk about standardization and then utilization management in the next few slides. So the first one is elimination. And I think the big one, take a minute in here to, one second. Anyone ever heard of a CKMB? Raise your hand, although I can't see if you raise your hand or not. I have. I bet many of you now have not heard of one because we don't do them anymore, right? It's something that is not routinely ordered in the evaluation of acute coronary syndrome and hasn't been for many years. So you can see this article came out in about 2014. This was by some of our colleagues over at Bayview, where at this time, troponin was becoming the primary method of diagnosing acute coronary syndrome. And so what they did was they actually removed CKMB from the orderings. As you can see right here, after they did it, can't order it anymore, right? Or people didn't. And obviously people had to go back and find it. So it's not like they couldn't order it. It just wasn't something that they could easily find. And you can see here as a balancing measure, they looked at, well, if we were ordering less CKMBs, were we missing people with heart attacks? And they were not in the post-intervention phase. And then what I thought was interesting too that they looked in this was, are we doing, a lot of times when you're eliminating things, are we making sure we're doing guideline appropriate therapy or standard of care? And they actually went up on it, which I thought was kind of cool. Another thing that we did at Hopkins and has been sprayed nationwide by Dr. Rock, who is one of our infectious disease doctors, was decreasing inappropriate C. diff ordering. As you can imagine, at least in Maryland, it's something called an MHAC. So meaning if it's found in the hospital, you may end up losing payment for it. So a health associated condition. And so people were getting tested that probably didn't need to get tested. And so Dr. Rock instituted this thing where she used the EMR to figure out if people were having stools, right? So did they have enough stools to have the testing? Did they get a laxative? And did they have a recent testing? If any of those criteria were met, this pop-up would occur. And this is the soft one. So this is just saying like, hey, guess what? These things didn't happen in the patient. They probably don't need a C. diff testing. It's probably not going to be helpful, and you're going to have a false positive. And about 15% stop. You could proceed if you felt like you need to keep going, and then you get this thing which said you really can't order this test, and this is what we call a hard stop. And it kind of forced you to read this thing that we've written, as well as saying that if you really, truly need this, you can call the lab and you can get the test done. And so you can see if you add up 15 plus about 60, there still are a few percentage people that still went and called the lab and got the testing done. So it did end up taking away about 75% of testing, which is pretty good. And then what you again want to see is, are you missing people with C. diff? So are we stopping a test and not diagnosing people appropriately? And as you can see here on the top line, that's the number of C. diff tests. This is at Hopkins Hospital. And then down here is the number on the bottom, number of positive tests. So we weren't missing any people who had what we thought was true C. diff. She also did this study at one of our other two hospitals that are considered community hospitals. So one is Howard County, which is actually located in one of our south of the institution, and then Suburban, which is another institution that is a little closer to DC in Montgomery County. So another way to eliminate, and something that I've been working a lot on and kind of started my work here in high value care, is reducing repeat labs. Specifically, we were doing a targeted reduction with an informative BPA specifically on hospitalized patients. And what we did was we met with various stakeholders that would be important in each one of these labs. And so you can imagine for hemoglobin A1C, it would be an endocrinologist. For HIV, it would be ID. For lipids, it would be cardiology. And we're like, hey, if a person got hospitalized and Epic had the lab value from a certain period, when would it probably not be useful to repeat it in a certain period? And we asked them all, and they came up with these time frames here. And so what happens is, and I'll use hemoglobin A1C as an example, is if the test was ordered on a hospitalized patient within that time frame, it would say, hey, guess what? There was a test, and it's kind of blacked out here or whited out here, but here's the value too if you wanted it. Now, do you want to remove this testing or do you want to keep it? So again, what we call a soft stop, not saying that you got to not get the test, but just reminding you that, hey, maybe the test was somewhere and you just weren't able to find it, because as we all know, the EMR is not the easiest thing to find testing in. And what we found with the lab test that we got the go-ahead for, so we're still going back to this, we haven't gotten all of these operationalized. The way that they said they do it is like you can do one at a time and we can see how it goes. And if people think it's okay, we can keep adding ones based on what we think would be a good one. So the ones that I have so far, so as I mentioned, we have hemoglobin A1C. And I know this slide is a little hard to read, especially with all the weird colors on there. So I tried to make it easy for you. So the blue line at the top is how many times it fired. So meaning how many times people in a given time period, in that given month, were trying to order hemoglobin A1C on a hospitalized patient within the last 3 months. As you can see, the yellow line shows how many people actually said, you know what, I don't need that test. I'm going to cancel the order and move on. And then that last line down there, the orange one, is how many proceeded with it. So you can see hemoglobin A1C, we did a pretty good job. And I think that's an easy one, and why we went with that one first, because a lot of people don't need one less than 3 months out. ESR wasn't as accepted, although we still, you can see here that, if we flip the orange and yellow line here. So, the orange one is how many people proceeded with it. And I think, again, this is a lot of times in our hospitalized patients, people are using this to make clinical decisions, even though ESR pathologically will not, like from a lab perspective, will not really change that much in less than 7 days. So remember, this was for 7 days. TSH, we had a pretty good, about half-half, if you look at the yellow versus orange line. So again, people are probably seeing this and just couldn't find the TSH. Vitamin D, interestingly enough, this was another one where most people proceeded with it rather than accept it. When really on hospitalized patients, I don't know how many people feel like the vitamin D is that helpful. Again, I just want to put out, this did not find the outpatient environment, and we have not moved there yet, just because that's a different clinical environment and different type of patients. And again, RNTI-BC was very similar in that people wanted, more people wanted to keep it rather than accept and not get that within that time frame. And I forgot what it was. I think it was a few weeks. Same with positive hepatitis C. I do think a lot of this, as I suffer through this as well, is that dialysis centers often want this repeated, even though it's in patients that they've had before. There's no reason, if once they've had positive hepatitis C, to repeat it again. And even though we still had people proceeding with orders over the course of the 23-24 period, we had a lot of cost savings. And this is actually the cost to the lab, where on consistently on a basis, $20,000 the lab saved by not running these tests, which is kind of cool. Okay, I'm going to take a minute to talk about internal variation. And I actually am going to add a little bit to this talk after having worked with a colleague over at Cleveland Clinic about variation. So variation can actually be good, and it can actually be bad as well. So obviously, I'm going to talk about trying to get rid of the bad variation. But in an article we're writing, we actually talk that variation may be good in that it allows for us to use our shared decision-making, patient factors, health system factors, to maybe do things differently with one patient versus another patient, even with the same condition, because that's what allows sometimes for us to be able to deliver the care that the patient needs. And really, in this age of personalized medicine, there will be a lot more internal variation. But what we want to make sure that we're trying to decrease is variation that leads to low-value care. And so I'll speak about telemetry, and I've been working a lot on this. Actually, back when Dr. Kime was probably still here, from what I don't know if he remembers or not. So this was our first telemetry order set, and this was in our previous EMR called Sunrise, or POE for some of you if you've ever worked in this. And we modeled it a lot after what they did in Delaware at Christiana Healthcare, where they put the I don't want to say the burden, but they put this on the nurses to help with understanding whether a patient would need telemetry or not. I mean, they found some good outcomes there. We did a pilot here at Hopkins on one floor, and it worked out, and the nurses wanted to expand it to every floor. So what we did was we had this little message in there that when you wanted to order it, it says essentially, you probably don't need telemetry for some of these conditions, so just like not getting people to order it up front. And these conditions were based off what they found at UCSF. Many people were getting it for that were not indicated by the ACC practice standards at the time. And then you would, if you want to keep going, again, it was a soft stop, or not even a soft stop, it was just an informational message. You could go ahead and order it in this whole system that we had. And we then said, okay, if you want to continue ordering, you need to give us an indication, because then that helped the nurses know what you were kind of looking for and the reason for monitoring, so that when they went back and reviewed the telemetry, they know the reasons for why this was on. Prior to any of this, actually, we had nothing. Like, you just ordered telemetry and it was on. And if you walked around Hopkins Hospital, you would see literally the telemetry monitors everywhere. As we moved to Epic, it actually would not allow us to use nursing discontinuation protocol anymore. And so we had to switch to a physician protocol where the physician would get the BPA as opposed to the nurse in POE. And here again, we kind of adapted a lot of our stuff from the old POE by asking them why they wanted it. Again, telling them, you don't need it for certain conditions, but then they got to still order it. And then as part of the BPA, which would fire based on the time hour, it would just say, hey, this person's been on for 24 hours. That's what you wanted for your indication. Do you want to keep doing this? And really, there was no way to discontinue the order from here. You have to click that manage order and go to the orders tab and then do it. So we eventually had many people just say, they would continue on with it. And I'll talk about that in a reiteration of this program later. But in just comparing the nurse protocol to the physician protocol, so everything before the green line is when we just had the old stuff. And then during the nurse discontinuation protocol, when we actually had that whole new order set that I mentioned, we dropped by a few hours, and it was significant. And then we had the physician discontinuation protocol, and we went up a little bit. And this actually made us a little concerned, like, why did this happen? We thought we were doing a good job, but our physicians worse at this than nurses. So one of our pros said, well, why don't you look at the number of telemetry orders and see if that changed? Because maybe it's just the sicker people are now on telemetry. And she was right. You can see here, before the green line, that was again before any order sets existed. Green, between green and purple was nurse discontinuation. And again, really no change in the number of orders. But when the doctors had to put the orders in, get the BPAs, you saw it went down significantly. So it definitely did. And the reason we went and dug deep into this is because we were physically walking around and didn't feel like then that many people were on telemetry. So that's why we dug a little bit deeper to find out why. The hours were pretty similar, but sounds like only the sicker patients stayed on it and the less sick patients came off of it. As I said, we found that having that one where the physician had to go into a separate place to discontinue the order was not as easy and probably led to a lot of people just bypassing it. So in this new scenario in 2019, we started a new way where you could actually discontinue it from the BPA. So here again is the BPA. It would say why you ordered it, what the indication was, how long you're supposed to be on it. And some of this other stuff comes up in there, but it's not pulled in from anywhere that is from telemetry. But it kind of just shows you like why you ordered it or why your colleague ordered it initially. And you can discontinue, address it in an hour, or continue telemetry. Oh, and one more thing too that we did with this as well is we initially had this running all the time. So if someone was ordered telemetry at 11 p.m., this would fire at 11 p.m. the next night. And then we found out that, well, the person who was on 11 p.m. the next day may not know the patient. So we restricted the hours to only 8 a.m. to 6 p.m., thinking that the primary person ordering the telemetry would be there during that time. And what we found was that the telemetry duration actually went down. So these are two different hospital systems. One is Hopkins and the other is Hopkins Bayview. Both are academic medical centers. And on average, they went down about 6 to 7 hours. That was significant. And this was definitely something, if you look at an interrupted time series, occurred at the intervention, so at that red line. And that's where you see that third row right there. Now, JHH and JHBMC, as I told you, had one set of physician discontinuation and then went to a different set with the new hour restrictions, and also as well as you can discontinue from the telemetry order, from the BPA, I apologize. What Howard County did, which is another one of our hospitals I mentioned earlier, they actually had nothing in this time frame before the red. And then when they did institute something, they had to institute the same thing we did because they really liked what we were doing at the AMCs. They had a decrease in 20 hours. And again, that was significant at the time of intervention as well, and has been maintained otherwise. Why we really did this work was to look at BPA, or what we're actually calling OPAs now, firing. Because the original reason they came to us, say, restrict the hours, was because this thing was firing all the time at like 10, 11 o'clock at night. People were ignoring it. And we thought by restricting it, it may actually fire less, and therefore it wouldn't have as many issues. And so what we found was actually the BPA fired a little bit more after the intervention, which we again found interesting. Like, why is it firing more afterwards? And so again, we did a little bit of a dive in and found that, well, even though it's firing more, there was a decrease in the intent to continue telemetry order, meaning that if you looked at that previous slide I had back, people were less likely to continue telemetry, and they're more likely to discontinue telemetry from the BPA. So even though it was firing more, people were using it more to essentially discontinue the telemetry on the patient, and that's why the hours probably went down. And then the other thing about daily labs, I always put up pictures to show kind of how our patients feel after like probably 3 or 4 days in the hospital. One thing we did too to help with internal variation is thinking about how can we give the residents feedback on their ordering patterns, because sometimes audit and feedback work in trying to promote standardization, decrease overutilization. So we went through 3 academic years. In the first academic year, we basically we didn't do anything. We just looked at their blood draws and orders per patient day, both at the halfway point and at the end of the academic year. In this academic year 2018, what we then did was we gave them weekly emails, and we only and at Hopkins, we have a firm system. So meaning that as an intern or a resident, you rotate on your general medicine service only with on one team. So we have 4, so I'll just say 1, 2, 3, 4. And if you are assigned to firm 1 as an intern, you stay on that firm for the rest of your residency. So we were able to kind of do a pseudo randomization with this. And they got the weekly emails with a dashboard. And then again, we assessed orders and blood draws per patient day. And then we turned theirs off, and then we gave it to the other interns on the other 2 firms. Again, assessed orders and blood draws per patient day. And then the last academic year, we did a different type of audit and feedback where we met monthly with the house staff, and we gave them firm label data. So not the overall, like not the personal ordering patterns, but hey, this is you as a firm, when you're on during August or October, whatever, this is how much you're ordering. And we gave away an award for the, least ordering firm. And again, we did the same outcomes. And we did that continuously over the last, during academic year, we did that over 12 months. So every month we met with the residents. And then here's just an example of the dashboard of what it looked like. So it would pull data from Epic and essentially give you your individualized data compared to others. And then, what labs you were ordering compared to your colleagues. And so really just to show you kind of how you were doing compared to your colleagues. And what we found was, again, something interesting. And again, with single site stuff, this is kind of what you see sometimes, is that if you took all academic years, and this is orders, and by orders, we lump things as like a CMP or a BMP. We didn't count like sodium, potassium differently. We said a CMP was 1 order or CBC was 1 order. Over the course of the year, the number of those orders went up significantly per patient day across all 3 academic years. And if you looked at, when we did the individualized intervention, the first half, those guys actually went up just as the historical people did. But in the method 2, when we gave it later, they actually didn't go up significantly. They actually went down a little bit, but it was non-significant. And what we thought was, in looking at this, is that maybe by getting at that point in their career, that they're developed enough to be able to take that feedback and utilize it in their future practice. And that maybe there isn't too early to give them this feedback data, and that they're not able to internalize that and use that to change their practice behaviors. And this was orders per day. We also did blood draws, or what people classically call sticks per day. And again, that significantly went up over all academic years. And then, really there was no difference between giving the data early versus late. So really this was to show that maybe we can decrease the number of orders per day that a patient is getting. And that can be helpful, right? Because if they're not getting a CBC every day, that's, 5 mils of blood that they probably won't get drawn. So one order can make a difference to the patient, even though they're getting stuck some amount of times. All right. Oop, sorry. I lost everybody. So I want you to think for a few minutes. What's the one thing you'll do differently next time if you're on clinical service? And then if you're near someone, share with them. If you're on Zoom, you can share in the chat. And now I need people to talk because I've been talking for 30 minutes straight. Let's see any chat activity. Saw anyone out there willing to share?
I'll talk, Saad. I got you.
All right, thank you.
That was a great talk. Hi, I'm Jody King. I'm the program director. I do some hospice weeks throughout the year. I'm glad you mentioned residents ordering labs because they fear they are going to be yelled at or mocked or shamed the following day for missing things. I think a lot of them order labs because some of the attendings like those labs ordered on everybody for some reason. But I think over time they've gotten more savvy at maybe not ordering the RPR on the 93-year-old woman from a nursing home. But so they've got a little bit better at that. But thank you for mentioning that. I think the daily labs is a huge issue. And, it takes us a few days to finally go, why are we still getting, pro-cals on this patient that popped out of the ICU, a week ago? The telemetry is also something that we are working on as well. The question I have is this: how do you reconcile certain things? So the C. diff hard stop is something that I struggle with. I rebel when I'm trying to be controlled by other people. But we definitely have a hard stop to the point where we have to call the C-suite to actually get it ordered. But I feel like that's more of trying to reduce hospital-acquired infection rates in our hospital than it has to do with cost-conscious care.
Yes. I mean, I think a lot of that, you're right. And you probably got the same thing because Claire Rock, who I mentioned, took that nationally. So I think that's why all of us had that same hard stop. And really it was for, we were getting really bad dinged on hospital-acquired infections, and we needed to find a way to decrease it. And so that's why the hard stop worked. Honestly, though, I'll be frank with you that I was surprised to hear when the residents said, we don't mind it. Like, we're actually okay with the hard stop, and they've asked for other things to have the hard stop. Obviously, it wouldn't be everything, but you're right. It was probably driven more by hospitals thinking about their bottom line than it was, for patient care.
Thank you.
Thank you, Dr. Pahwa. I think this was an excellent talk.
I'm not finished. I have more. I was just trying to pause. Hello?
Great. Then I'll keep my question for the end.
Oh, okay. Yeah, I was hoping people would, I was trying to make it a little more interactive by having people kind of talk about what they would do differently. But if people were not awake yet, that's okay. I'm fine with that. It's only like a couple more slides, and then we can do plenty of questions. I always leave time for questions. So just in summary, as hospitalists, we have a role in the value-based care, both at the bedside. So I mentioned, and as your program director mentioned, we have roles when we're teaching our residents, when we're role modeling for them, and we need to make sure that we're there for them and help them understand, because they get a lot of imprinting during this time, and that will carry on once they walk out of our four walls. But we also have roles in the health system. I think hospitalists, I think we've defined ourselves in quality improvement, and that can be various elements, but definitely in value-based quality improvement. And so we definitely have that role that way. Elimination is the most common way that I found that we've really reduced testing. That is probably the easiest, right? Just take it out, or on round say we don't need it. So definitely thinking about what is not necessary at this time in this patient would definitely be the best way. I think a lot of times go in the easiest way. As I mentioned with internal variation, I didn't really talk about the length of time a lot of this took, but a lot of it required iterative cycles. We had to go back to the residents or the faculty or whoever and say, okay, what's working for you, what's not working for you, what's working for the Epic system, what's not working, and make mild tweaks. And what's interesting enough, I was very surprised how like these tweaks allow for publications and scholarship when I thought that, oh, I already did telemetry, we're done with it, we can't really publish more on it. But these tweaks were kind of helpful in showing us that, hey, we can show you different ways of doing things. And I think it's really important in the day of the EMR when like every thing does not have a single solution. Definitely work leader health system. I think I've been fortunate that, and I'll mention, I'll thank her, is Dr. Johnson, who's led a lot of this work, has helped us with this and our electronic health records to determine effectiveness. Because if you're just doing stuff to do stuff, it's not helpful. Make sure what you're doing is helpful, because there are some things we have stopped doing because it was not helpful at all and probably more harmful, or even just made physicians angry, which is not a good thing. Dr. Kaya mentioned that we were, we had started this organization called the High Value Practice Alliance a while back. And I didn't want to make this like a Hopkins specific, like we do everything great here. So there's a QR code there. That is all the abstracts that have been submitted since 2019 on people doing great quality improvement work. And I'm sure there's some of your colleagues are in there too, because I know I've seen EVMS at this meeting. So please take a moment and go to that slide set or this website and just take a look at kind of the awesome stuff that people are doing in quality improvement in the United States and some international too. And I did want to thank Dr. Ham mentioned Dr. Feldman, who's been great. So many of you may know him as the Things We Do for No Reason guy, but has been a great mentor to me and supported me through all this, as well as Dr. Johnson, who has really like got the health system to think about this and makes it easy for us to be able to do this work here at Hopkins and spread it nationally. All right, I'm officially done now. Oh, and
Thank you, Dr. Pahwa. It was an excellent talk. So I'll start off with my question. I can see a lot of artificial intelligence already in your talk, where we had clinical decision support, and that was there to ensure high-value based care was being implemented. We live in an era of ChatGPT and, of course, this generative AI. Do you think going forward there would be a role of generative artificial intelligence in improving high-value based care?
Oh, most definitely. I mean, I think there's still a lot of work to do because I don't think our AIs are that great yet for a lot of things. I think many of you used it in ChatGPT and probably if you have notes that can, be generated. There still requires a lot of human input, but I do think especially with predictive models, some people are thinking about how can I take some of the data that's already been collected on the patient and predict and tell you like, how good is this next test going to be on this patient, right? And then even using AI to tell you like whether this test even means anything in this patient or whether there's some pathology behind it. So I think AI has a role. I think it's going to be a lot of work and probably not something we'll see like consistently effective for the next 5-10 years. Interesting, I was reading an article about using AI to grade student notes. And, obviously that's not like a high thing, but, the student notes count for their grade. And so you want to make sure that the AI is doing it properly. And I mean, they use like 5 years worth of data to be able to make sure that AI could grade those notes accordingly. They're still doing Spearman correlations on it to figure out if it's working or not. So it hasn't gone live yet. So again, a lot of work, but I think it will be helpful soon.
Great, thank you. Any other questions from the audience? Yes, please.
We talked about what we shouldn't do, but
Yeah.
I could think of two examples of perhaps what we should do to provide high value care to the patients and their families. One was when Tina Chang was chair of pediatrics, they offered flu vaccinations to all family members.
Yep.
And talking about tests that we had to do in the early 1980s, we were asked by the attending the next morning whether it was a DVT or pneumonia, did you do a pap smear? Because of the high risk of cervical cancer in the area. So the question would be, are there things that should be done to educate the family and to create better long-term health outcomes for the community?
Yeah, I completely agree with you that a lot of the stuff I talked about was don't do, and I didn't really talk about do, because you're right, there are some high value practices we don't practice that if we were nudged a little bit, and I think this is where a lot of the nudging will come in, and helping, making sure that people are doing some things. So, making sure, like, you're exactly right. Like, when our patients walk out, did they get their vaccines? I think when COVID occurred and we were doing COVID vaccines, they did a good job of that, but a lot of that has dropped off. And definitely, I do believe that we need to have more of those. You need to do better. You need to do this to be better for the care patient. I'm trying to think of anything we're doing right now is in that line. I can't really think of anything. A lot of it is like decreasing stuff. Actually, you know what? I take it back. There's all nudging in asthma care to improve, and GDMT too, like in heart failure, to improve the medications they get on discharge, make sure they're on the appropriate medications to help control their chronic disease.
One easy thing that we mentioned here about 20 years ago, but never got done, was taking all inpatients on the adult side who are not up to date on colorectal cancer screening, getting a FIT test. The problem was the long-term outcome to making sure it got done, but you guys have a lot of surgical residents, GI fellows, so that would seem to be a pretty easy project to do on O3 or Janway or somebody.
Yeah, you must have recently been here because you know all the floors.
1983. No, involved with the Children's Hospital too.
Oh, okay.
Dr. Kayam's ringer.
No, you're right. I mean, I know the GI fellows have been working on a lot of that stuff too, but it's also getting that colonoscopy done as well. So if it were to be positive.
Great. Any other questions? I'll hand over to Dr. Kayyum.
So, I mean, it used to be that, for many of these activities, we would say education, a lecture on this or a lecture on that is going to change practice. But I did not see in your list of things that are effective any of the quote unquote education piece for changing behavior in our practice, either doing or not doing something.
Yeah.
And by the way, Dr. Walholz is still involved. He was asking the earlier question. He's still involved with the IM residency program at Hopkins, all in a different role, and supporting the residency program there. He is a resident. He was a 1983 resident class at Hopkins.
Okay. No, he just mentioned OSER 3, which wasn't a clinical environment until the last 2 years. So I was if you weren't here, you wouldn't have known that. That's why I was fascinated when he said that. Going back to your education piece. Yeah, I mean, while education is nice, as we know, it is not lasting for several reasons. One is just the way we do it. Again, I mentioned early on, a lecture is not the best way to educate people, as we know, yet we still do it consistently. And then I think just the ever-changing and over the last probably 20 years, probably the ever-changing environments in any health system where you walk in, 2 months, 3 months later, it's a new person probably in that position or role or something like that, where, education will actually probably, the time invested in it is not going to be that great. And really what we found is the EMR is probably the best way because that's what everyone interacts with in order to engage in patient care. And then, making sure that I've actually heard people say like, oh, the EMR taught me something. So sometimes leveraging that as an education tool rather than a straight up lecture. And I think we've seen a lot of this with UpToDate, right? Like places that have UpToDate, people go to that and use it, and they use it in their clinical care. So point of care kind of education is always a great way. It pains me to say, Rehan, as an educator, that education doesn't work.
Dr. Hanrahan?
I just want to mention that, so I see a huge amount of overuse of all kinds of things. And actually, it's been surprising to me how difficult it is to get people to stop doing some of these things that are really obvious.
Yeah.
Completely useless tests that are of no value whatsoever to the patient. But what I've seen to be most effective is giving people their individual data and comparing them to others. When you do that, physicians don't like to be outliers. They don't want to do worse than their peers. And so, it's unfortunate that we don't have a great way of providing that data to everyone, because I think that would actually be the most effective way of getting people to stop ordering some of this useless stuff.
Yeah, you bring up a good point. So Steve Frank, a while back, one of our anesthesiologists put up all the blood product transfusion rates of the surgeons, and he literally just like wrote on a piece of paper and stuck it up in their in the room that they scrub in, the scrub room, or change in this, and he found huge effects, right? Like all of a sudden the surgeon's like, I don't want to be that one giving that much blood. And that's what we thought, and maybe I glossed over too quickly, and I apologize, about the lab data. We thought that individualized lab data, like ordering patterns for the residents, may cause them to be like, you know what, the guy sitting next to me, although they would know it, but my colleagues are ordering less labs than I am, and why is that? But we actually found it to have a negative effect, where they were like, this is not right. And so a lot of times, while individualized data is a good way, it has to be done in the right place. We learned a lot, because people have to believe the data. So if people don't believe the data, then they won't follow it. And I think that's a lot of things that we suffered in at least the perception. But as I showed you in my data, it actually bucked the trend, right? So even though the residents didn't like it, it did work in a little way.
Yeah, just one more quick comment on that. I mean, you have to label what's desirable and what's undesirable.
Yeah. Which is always hard with labs, right? We've always said this since we don't know what the right number is. I think Lenny and I will always say that on average, you should only be sticking your patients once a day for labs in the hospital for the most part. And that's average, right? But as you said, people don't listen to us. They think we're the old people around.
Well, it's almost 1 p.m. Thank you so much, Dr. Pahwa, for your wonderful talk. We'll definitely plan a visit next time in summer, so that the weather is more favorable and you can make it to Norfolk in person.
Awesome. Well, thank you all for time. Thank you for letting me talk to you. I really appreciate it.